Hello everyone. So my name is Kit and this is Ida, and we will be spending the next hour talking about emergency regimes, but mainly the sugar tax and how it has impacted on our practice in the last year or so. We'd just like to say thank you to VitaFlow for having us today. It's been a great day. Let's get started. So firstly, we'll be setting the scene. And discussing the current practice in emergency management in both children and adults. You might recall us sending out a survey a little while ago, so we will be going through those results. Sorry. Thanks. And so thank you very much for completing that survey. We had a really good response, didn't we? We'll then do a little interactive session with you all to raise your blood sugars after lunch, hopefully, and also briefly touch on the cost of glucose polymers and alternative drinks. So the first time the sugar tax came to our attention was back in March 2016, where the government announced plans for a tax on drinks that have no nutritional benefits and contain more than 30 grams of sugar per serving. So for instance, a can of Coke has got 35 grams of sugar. So the reason for doing so is to try and reduce overall sugar intake, particularly in teenagers, and therefore try and somehow combat the obesity issue that we've got at the moment. The drinks industry reacted, as you can imagine, and they reacted by saying that it's ironic that they are being singled out when they, in fact, started reducing sugar content of their products back in 2012, and also they've actually put a plan in place in order to reduce overall calorie content, the overall calorie content of their drinks by more than 20% by 2020. So the final draft for the sugar tax deadline is set for April 2018. So it hasn't actually come out yet, but as we all know, people have started making changes. So in December 2016, we were giving a little more information and a little more detail on what products would be affected. So all soft drinks containing more than 5 grams of sugar per 100 mils, and the tax would depend on the sugar content of those drinks. So fruit juices, they were exempt due to the fact that they technically count as one of our 5 a day. But we're recommended to have no more than 150 mils per day. And also, quite interestingly, milk and yogurt-based products were also exempt due to the fact that there's concerns about calcium intake in teenage girls in particular, and so the government thought that taxing those products would be counterproductive. So the money raised will go to the education for school sports. So in March 2017, the level of tax was announced. So there will be 2 arms. Drinks containing 5 grams of sugar or more will be taxed 18p, and the consumer cost will increase by 6p, whereas soft drinks that contain 8 grams of sugar or more will be taxed 24p per litre, and then the consumer cost will increase by 8p. So as I mentioned before as well, as I touched on briefly, as we all know in this room, and we're very well aware that the soft drink companies have already made some changes and reduced the sugar content of some of the drinks out there. Hence, this might also impact on the revenue for the education of school sports. So, we had the budget announced for 2018 the other day, but they left us out. There's nothing on the sugar tax. I think there's more burning issues at the moment for them to tackle. And so I was hoping to have more of an update today, but actually there isn't one. And so I was also reading that they're actually wondering whether April 2018 is the realistic deadline, and actually whether the sugar tax is going to be implemented. Right, so what has the BIMDG done following these actions? Well, I did a very, very brief presentation at BIMDG in April this year, just on what we've done so far, and we've updated the oral emergency regimens by removing the list of alternative drinks in place. And in place, we have added a note on the sugar tax, just explaining what it is, what is going to happen, but also saying that we don't know which drinks are necessarily going to be reduced, or the sugar content of those drinks. We don't know all the drinks that are going to be reduced in sugar, so because that's up to the individual companies. We've also asked that all centres try to prescribe glucose polymers for all of their patients requiring an ER, just to make it, to avoid confusion and make it a bit easier for patients to follow. And then at BIMDG, we also discussed reporting any adverse events, and I took on the responsibility of doing so, but no one has reported any adverse events as of yet, which is quite interesting. So I've got nothing to report on that either.
So thank you, Kit. And as Karen said, my name is Ida, and I actually used to work with Kit at the Adult Metabolic Centre at the National Hospital. And in the last month, I've moved to Great Ormond Street into paediatric metabolic. So it's been very interesting being able to see the metabolic management from both ends. So I'm going to do a very quick background to emergency regimens and practice in paediatrics. I think this could probably be a whole separate talk unto itself, so I'm just very quickly just going to go through that. Okay, so as we can see, emergency management is not a new thing. It's been known for quite a long time. It's been known about for quite a long time, and it was actually described in 1974 by a lady called Dorothy Francis, who you might have heard of. She's a dietitian in Melbourne, Australia, and it was mentioned how infections and trauma can cause catabolism, which does result in the build-up of toxic metabolites, for example, leucine in maple syrup urine disease, which can be life-threatening. And I suppose this sort of build-up of toxic metabolites is more threatening and life-threatening to say the build-up of phenylalanine in PKU in children during acute illness. And it was described back then as well how vigorous treatment with adequate calories, either orally or through IV, was essential in order to minimize catabolism and the build-up of toxic metabolites. And as we can see, it was also known that this should only be a short-term temporary treatment, and diet should be introduced really as soon as possible. So what was described in 1974 is similar to what we kind of know now and actually follow today as well. So I suppose overall what we're trying to do with emergency regimens is prevent any changes that occur when fasting. And what we're trying to do is minimize catabolism and the accumulation of potentially toxic metabolites. So this could be your ammonia in your urea cycle disorders or organic acidemias, or it could be like leucine in your maple syrup urine disease. And essentially we're trying to do that by providing an exogenous supply of glucose in the form of a glucose polymer. And what we want to do is we want to try and promote anabolism. But for sustained anabolism, we also require essential amino acids and vitamins and minerals. So again, that just highlights how emergency regimens are only a temporary measure, and we should be trying to introduce the child back onto their usual diet as soon as possible, even if that introduction is over a few days. And we do try to manage patients as best we can at home. But, sometimes it's just inevitable that patients will have to go to hospital. And, that is sometimes our decision is to advise patients, okay, we think that you now need to go to hospital. So it does put a lot of kind of pressure and responsibility on us as well. But overall, we're aiming to prevent metabolic decompensation. So practice in paediatrics, which I'm sure you're all very aware of, but we'll just give a whiz through it. So there's different types of emergency regimens. So we have our standard emergency regimens, for example, for the organic acidemias, urea cycle disorders, fatty acid oxidation disorders, such as MCAD and ketotic hypoglycemia. And then we also have our disorder-specific emergency regimens, which have the same core principles of the use of a standard emergency regimen, but just have some added components, which we'll go through. And then there's also some disorders where there's no formal emergency regimen needed. For example, in PKU, however, I think when these patients are unwell, we do manage them, and we do have our own strategies, but there's no kind of formal guidance or no particular regimen that we have been advised to follow. And I'll touch on that again, PKU with commercial drink shortly. So with the standard emergency regimens, we try to give a glucose polymer. So as you know, there's a variety of glucose polymers out there to choose from. And generally, the volumes and the concentrations will differ depending on the age of the child. But generally, there's higher volumes and lower concentration in infants compared to older children. And in terms of the concentration, there's no real evidence behind what percentage to use for what age. However, there has been publications. So there was one publication in 1992 by Marjorie Dixon, who's a dietitian at Great Ormond Street, and Professor James Leonard, who was a metabolic consultant there. And they published their practice in the UK. And I think this is probably what most people tend to follow in terms of concentration for age currently. And they're the concentrations that I've put up there. However, as we've probably learned over the last few days, practice does vary across Europe. And there was a publication in 2009 by Johan van Hoves, and he spoke about kind of published what they do in Colorado and in Belgium. And they actually use slightly higher concentrations. For example, for 0 to 12 months, they use 15%. For 1 to 12-year-olds, they use 25%. And then for over 12-year-olds, they use 30%. So we can see that practice does vary. But what is really important is that with emergency regimens, that it's small, frequent feeds are given both day and night while the child is unwell. And we usually advise these are given orally every 2 to 4 hours. However, you know, some children do have, or might have to insert an NG at home to have an emergency regimen. We sometimes see that, or some children have PEGs and or gastrostomies, and the emergency regimen might have to be given through this at home. And it's also important to remember, although they're called standard emergency regimens, there is other aspects to them that we need to consider as well. So for example, with urea cycle disorders, we need to consider that they are taking their for example, their nitrogen scavengers alongside their emergency regimen. So, you know, there is certain conditions where we have to bear in mind that they're medications and they're essential to be taken alongside this as well. And then also, we need to try and make sure that we are returning to diet within 24 to 48 hours. And again, that's because we need to start introducing, we need to start introducing essential amino acids, vitamins and minerals, or sometimes this can actually, cause levels to increase further. So again, it's just highlighting the importance of introducing the normal diet within 24 to 48 hours. As we can see, the kind of volumes that are provided for age and the calories they provide, they don't really meet the nutritional requirements for any of children from 0 to 18 years of age. So, it really is a short-term measure. They're not nutritionally complete. They just contain glucose. And it's essential that, if patients are on them, or you think they need to be on them for longer than 48 hours, that we're really considering an admission to hospital at that stage. And disorder-specific emergency regimens. So as you know, there's certain disorders which, as I mentioned, the core kind of principles of how you use these and when you would start these are the same, but there's just some added components. So for example, with the GA1s, you would continue their usual amino acid supplement, and for the MSUDs, you would aim to do the same, and also you would continue with your usual dose of valine or isoleucine, or actually these might need to be added into some children's emergency regimens to help bring down the leucine levels. So commercial drinks, which has kind of brought us here to talk about the sugar tax today. So these used to be a very, very useful tool in practice, particularly to patients who I think were struggling maybe to take glucose polymers. And although it is, there's goodness behind the strategy, it's great for the management of obesity. However, from I think a metabolic and a diabetes point of view, it wasn't so good news to us. So Lucozade have actually changed their formulation already. As you can see, the glucose content or sugar content is reduced by almost 50%. Some of the other drinks I looked into, they haven't changed their sugar content yet, but as Kit was mentioning, the deadline is April 2018. So we don't really know when they're going to change. They could change without us knowing, so it's important to always kind of keep an eye on them, but we are trying to start changing patients over now. So anyone who's been on Lucozade, we've had to change over, and I think that has probably been the most problematic drink because it's the one that most of the patients were using as an emergency regimen. Coca-Cola, we don't know even if the sugar tax goes ahead, if they will do anything with their sugar content, as they feel taxing drinks is not the best way to go about decreasing obesity, and they feel they are doing enough already by creating alternative drinks such as Coke Zero and Diet Coke, etc. So we're not sure that they will follow. So if they don't, the price of that will go up. So yes, these drinks proved to be very useful, as they would have provided, depending on how much carbohydrate you were aiming for, based on the age of the child, they would provide these. But now with the decrease in sugar, we feel that the volumes that are required to meet that carbohydrate content is just not practical for children or adults who are unwell. And also, I think we need to be mindful that for these drinks that are changing, that they're also for example, Lucozade, which has reduced its sugar content, but has now added in aspartame. So I think, maybe in PKU when children were unwell, or, maybe in adults, maternal, when they were unwell, we might have recommended sugary drinks to help keep their calorie uptake up. But now aspartame has been added, so it's also mindful just to keep that in mind for management of that as well. So what we did at Great Ormond Street following the sugar tax, we have a database of all children on emergency regimens. So we've got 480 patients on our Excel sheet at the minute. 230 of these are MCAD and ketotic hypoglycemia. And we had to send a letter out to all families to update them on the sugar tax. So that was quite a big piece of work that had to be done. And we asked them to contact the department if they had any issues, or if they were using commercial drinks, because we would now have to change them over to glucose polymers, or at least work with them to see what would work for them. And actually, surprisingly, our experience at Great Ormond Street was that we didn't find that there was many problems or with people switching over. It was just kind of, okay, that's a shame, but we know that we need to take these drinks, so it's fine. And we haven't had any kind of reports of any issues similar to what Kit said earlier. So, and I also emailed our consultants and our CNSs just to see if they'd heard anything in clinic that they might not be telling us, which happens sometimes. And they too said that they hadn't come across any kind of reports. So that was good to hear. So I'm just going to hand over to Kit for practice in adults.
This is really quite brief. So in adults, it's fairly straightforward. It's disorder dependent, of course, and we tend to use glucose polymers and or fat emulsion, so we do combine the two every now and again, but for the purpose of this presentation, I am just going to solely focus on glucose polymers. So we aim for 25% glucose, so that's approximately 50 grams of carbohydrate every 2 hours. And of course, we look at the clinical picture. That's always what we tailor our dietetic management to. But yeah, so it's roughly 50 grams of carbohydrate every 2 hours. And also what we did at the National Hospital, we informed patients in clinic and we gave them all updated emergency regimes to take home and have a good look at. And again, we would prescribe glucose polymers for almost everyone. And if that wasn't suitable, we would then talk through a plan that was suitable for them. But to be honest, we haven't really had any issues, thankfully, as of yet. Right. So this is the SurveyMonkey results that we sent out a few weeks ago, and thank you for to VitaFlow for analysing the results. So we had a really good response from all over the UK, Scotland, Ireland. So thank you very much, and Northern Ireland. Which patient group do you manage? So it's mainly pediatrics, but of course we've got the adults too, and a combination of both. So did your center inform patients about the sugar tax? Yes, and someone said no. So I would assume that that's probably when they would, or it might be that they weren't using commercial products anyway. So their patients would already have been prescribed glucose polymers. Has your center ever used commercial drinks for standard emergencies? Yes and no. So I'm assuming that question 3 and 4 tie in together. And has your center changed its emergency regimen practice since the introduction of the sugar tax? Many have, and a few haven't. So again, I suppose that would tie in with question 3 and 4. If yes, what have you recommended instead of commercial drinks? So, some people say glucose polymers only, glucose polymers and... Okay, so we asked also about practical changes, and a fair few of you said that you've had no issues so far, which ties in with the fact that I haven't had any adverse events reported, which is a good thing. So we also had a few comments about the fact that no one likes change, but after a few goes, you found a solution to the problem, so that's good. So that's either that you found the right glucose polymer for the patient, or you found a combination of commercial drinks and glucose polymers, or commercial drinks only. Also, we have to remember, as always, it's patient choice. So prescription of glucose polymers or individual recipes combining glucose polymers and drink alternatives. Also, one person said that they're using jellies, sweets, and or glucose tablets, which of course is also an alternative to a drink if the patient is able to tolerate that, because they're easily absorbed. Also, like we discussed before, some centers sent a letter to all patients informing them of the sugar tax and the changes that were made, and others just reported the changes in clinic, and where some people did both.
So this is one area we don't seem to have a problem with the GPs. So there doesn't seem to be very many at all problems. Maybe we can, if somebody wants to discuss, when we kind of have a discussion later about, obviously there might be 1 or 2 people who have had problems, so maybe we can have a chat about that. But very encouraging to see overall that there hasn't been many problems with GPs prescribing glucose polymers. And this was just a question, I suppose, was just out of interest, really, just to see what people do with emergency regimen management, and to see how many people are incorporating fat into the use of emergency regimens. And it seems to be pretty 50-50. And people gave some good responses as to when they would use these and what they would use. So the disorders that people were kind of incorporating long-chain fats were things like maple syrup urine disease, GA1 urea cycle disorders, and organic acidemias, and particularly if they might have been struggling with volume, and they were trying to add some fat in to help increase the calorie intake. Also, people were adding some MCT into emergency regimens for CPT2 deficiency and for some long-chain fatty acid oxidation disorders again. And I think it was the same thing, just to try and increase the calorie intake, especially if volume was, if they were struggling with volume, or should the child be fluid restricted. However, people did mention that they wouldn't use fat in an emergency regimen if the child was vomiting, because this could possibly further exacerbate the problem. So some products, for example, some of the products for MSUD, if you're using when they're unwell, then they do contain fat. So sometimes it might be switching to another product that doesn't contain fat if the child is vomiting. And this was an interesting question to throw in at the end. So we just asked everyone if there was anything anyone could change about emergency regimens. What would it be? What would be the perfect? Solution? So there was some really interesting answers that came back. So some people mentioned flavour, which I think is a really good one. So we already kind of advise, you can add some squash to your emergency regimen to make it taste a little bit better. But maybe if there was flavour sachets, or kind of some top tips advice as to how patients could make them taste even better, that might be good to improve adherence. Some people have said to add electrolytes to the emergency regimens, which is a good suggestion. Someone had a really good suggestion about a tablet form. So, for example, adding 5-gram carbohydrate tablets to a given volume of water to get the desired carbohydrate concentration. And they said, so this was that you would have the one product and you would only have to increase the tablets as the concentration would increase with age. Someone also said a few people actually said about ready-to-drink glucose polymers. So I know there is some available already, but the carbohydrate percentage is really high, so they're not suitable. But you know, if ones were made that were suitable for different age groups, it would kind of eliminate the whole having to make up the glucose polymer. People recommended having a scoop with all products. So I know the tins already have a scoop, but you know, maybe some of the sachets, if they also had a scoop, because I think people mentioned about if they are combining commercial drinks with an emergency regimen, that they need a scoop to be able to kind of get the accurate amount of powder to add to the commercial drink. Instructions on sachets was another thing that was mentioned. And a top tips leaflet to go along with the emergency regimens. Again, I think just to give some ideas about how they could be taken, or how you could flavour the emergency regimen to make it a little bit more palatable. And they all said that, you know, the sachets seem to be, you know, one of the best way forwards in terms of saving time to make up these emergency regimens, and that they would wish that other companies would develop these, because there does seem to be a preference in flavour between different types of glucose polymers that are currently being used. So now for the fun part. We are going to get you to taste a number of blank products, and that VitaFlow have kindly arranged to make up for us. And you should be given maybe an answer sheet where we're going to get you to give a go at guessing what you think you might be drinking. And then there shall be the big reveal to see what you've got right and what you've got wrong. So yeah, enjoy. So I've just been told that VitaFlow have actually responded to some of the requests already about glucose polymers. So they have developed a top tips leaflet and how you can add flavours to the emergency regimen to make them taste a little bit more palatable. So we will drop one of these by for everyone so that they can take home, but they're hoping to develop a pad where you can just tear these off for patients and hopefully give out to them in clinic. So thank you, VitaFlow. Right, so you were right. A was water, B was SOS 10, C was SOS 25, D was MaxiDuo, E was the Ribena ready to drink, F was Ribena in volume of to give 25%, and G and H, sorry, I missed those ones, was Tropicana Pineapple Plain, and H, Tropicana Pineapple 25%. So was anybody horrified by any of the taste of any of them, or? 25 was the sweetest, yeah. Do you think you'd struggle to drink that every 2 hours? So yeah, we just thought that would be good to do. Just, I'm sure some of you have tasted them before, but for those of you who haven't, just to get an idea of what the SOS tastes like, and also what is being done with people who might be struggling with glucose polymers alone, that they might be mixing drinks, and just to get an idea of what it actually tastes like if patients ask. So that was that.
You've obviously got a very experienced palate, which is excellent, because you got them all right, more or less. Well done. I just thought I'd add this slide just because obviously there's a new cost implications for the GPs in particular, because we're taking away, or most of us might be taking away the alternative drinks and then prescribing glucose polymers. So I did an average of the cost of all the glucose polymers in the market in the UK at the moment, just to avoid being biased. And that was roughly 0.57, well, so 57p per drink. So if we say we make it up to 50 grams of carbohydrate, then that would cost the GP 57p on average. Now, the glucose polymers fall somewhere in the middle when we look at the other drinks, but it's really the volume that we would be looking at. So you can tell that, or you said that the 25% is the one that's the sweetest, and it is really sweet. So imagine drinking that every 2 hours when you're not well anyway. And we're just saying, just get it down, just try and drink it, but it is really quite difficult. But I just thought I'd show you the difference in the prices, but also the volume of the drinks that we are asking patients to consume. So just a few closing remarks. As we know from our survey, practice remains a little bit varied across the UK, but again, patient safety comes first, and I feel that we are all doing our very best at keeping our patients safe. And as we mentioned before, the deadline for the sugar tax is April 2018. Now, they mentioned somewhere that they might include sugary foods as well, and that's yet to come, and I was hoping that perhaps Wednesday would have given us a more, clearer picture, but it didn't really. So thank you for listening.